Yeah, thanks a lot. As you know, in the program it was written that today will be a lecture again with regard to non-Hodgkin lymphoma by Willi Wössmann. But I think, as I told some of you, he had a bicycle accident and has broken his humerus and could not join us. And this happened in the end of the last week. So I jumped in and I decided that we should not have a lecture again, but discuss a few challenging cases with each other. So it should be really an interactive session, and you're invited to comment. And it is also not like that there's always a clear answer what you do with these patients. It's not black and white, and it always depends on your resources, on the specific situation, on the day this patient comes to your ward. So it should not be something where we have a clear answer to everything that I'm going to show you. Just very briefly, short introduction about non-Hodgkin lymphoma. I think you all know that non-Hodgkin lymphomas are a relevant cancer for all of us, as they belong to the highly malignant lymphomas, and they represent the third most common cancer in childhood and adolescence, as you know. And you know that broadly in childhood and adolescence, we differentiate between 3 or let's say 4 groups of non-Hodgkin lymphomas. We have the mature B-cell neoplasms with Burkitt's lymphoma, leukemia, DLBCL, and primary mediastinal large B-cell lymphoma. Then we have the lymphoblastic lymphomas, you know very well. Then the anaplastic large cell lymphoma, and a topic in which I was always interested in my professional life, which is rare NHLs. We have the pediatric type follicular lymphomas, the pediatric nodal marginal zone lymphomas, and others on which we have worked a lot during the last 2 decades. You can see the frequency of these 4 groups. Then with regard to the staging system of NHL, this has been discussed. In the liquid tumor crack, we had this old St. Jude's staging system, which was invented in the mid of the 70s. We have updated it already also some years ago by the so-called International Pediatric NHL staging system, which is more precise, especially with regard to extranodal sites of involvement. And it also asks for more precise analysis of the CSF and bone marrow, not only by cytomorphology, but also by FACS analysis and molecular genetic tests. But I will not go through the details. So let's start with the challenging cases. So we start with this patient here. This is a patient that entered our emergency department because the parents recognized that there is a tonsil with this tumor, let's say. What would you do with such a patient to establish a diagnosis? What are you interested in to know about this patient? Jelena is giving the microphone to those who want to comment.
First thing.
I mean, depending on what time the patient presents, him or herself, but probably do a clinical examination, check for liver, spleen, other lymph nodes, clinical history of infection, and then if you're super fancy, you could do a swab and check if there's any malignant cells on there.
Okay, answering your first question, we did, of course, a full clinical examination of this patient. And there were no other pathologies in this patient. The patient was doing very well. No enlarged lymph nodes, no other symptoms, no B symptoms, nothing. Your colleague wanted to say also something?
How old was the patient?
The patient was 7 years old. Sarah?
I'd want to know about the timing of the evolution of this. Has it been noticed over days, weeks?
It was a very short period of anamnesis. As far as we got the information from the parents, they saw it, I think, they observed it for a few days growing very rapidly.
Yeah. And is it causing any problems like snoring, sleep apnea, any kind of red flag symptoms?
No, but he had some pain, if I remember correctly. She reported about some pain there when eating, but no problems during the night when she was sleeping. That was recognized by the parents. Okay, then let's continue with the diagnosis. Fiona talked about something like a swab. What does this mean? You take a swab and no, this I did. Yes, we did, of course, the swab because when we think about a malignancy, there are not so many differential diagnoses possible in such a situation. You might have a pediatric type follicular lymphoma there, but you might also have a highly malignant lymphoma, and Fiona said it correctly. We made a swab, did a tumor touch imprint, made a Pappenheim staining, and had immediately the diagnosis. So we saw already the Burkitt cells. So we could very easily establish by cytomorphology the diagnosis in this patient. What would you do in addition if you don't believe in your competence of cytomorphology? Let's say it this way around. You could make this is invasive. Yeah, this biopsy you need a surgeon or an ENT specialist to do this. But what you could do in addition, you could do what? Yes, we of course did this, but the blood tests were completely normal. And also the biochemistry was completely normal. No increased LDH levels, no increased uric acid. You could do
bone marrow aspiration?
This will be definitely needed for staging, but let's say I give you the information already now, it was completely normal. The bone marrow. What could you do?
You could do a FISH analysis on the smear that you did?
Yes.
Check for c-MYC?
I think, yes, this is important, but what you do before you establish the immunophenotype, because you can make by a swab also a tumor cell suspension. You need just very few cells, and we did, and established the mature B-cell immunophenotype, and then we did what you are saying. We performed the FISH analysis. It takes 24 hours, and the diagnosis was clearly established. It was a Burkitt lymphoma with a mature B-cell immunophenotype having a classic translocation 814. So we did not need to be invasive in this patient to establish the diagnosis. Of course, you need the further staging procedures. As you said, you need bone marrow. You need also, of course, sonography of the abdomen, an X-ray, sonography of the neck, and a lumbar puncture to be sure that it is a localized disease here. And by this, the diagnosis was clearly established. And it is what, let's say, it's a, sorry, Alfred, this was, of course, let's say, a Saturday afternoon patient. So you did not need anything else than yourself, making a swab, making a tumor touch imprint, and establishing the diagnosis. Sorry.
I mean, it sounds really amazing, but it's, for me, a bit Dr. House. So you did not do any imaging, nothing. This is, you went straight for this. It sounds really cool.
Yes, I would definitely do in such a patient immediately a swab, because this is not invasive. I bring it to the lab, they do a Pappenheim staining, and I have the diagnosis. And then I, of course, work according to the protocol to have a complete staging. Yes, here you see this once more the same picture. And at that time when we had this patient, we had the so-called BFM, NHL BFM rituximab window trial open, where all our patients got only rituximab on day 1, and we didn't do anything until day 5 to see if rituximab as a standalone drug is effective in such a patient. Here you can see the swab. Sorry, I forgot to show it. It's, I think, very clear Burkitt cells. We discussed it in our group as well. In the liquid tumor prep, you see the blue cytoplasm, you see the vacuoles. The diagnosis is definitely established only by this. And here you can see 1 day after rituximab and 3 days after rituximab. So only the antibody led to a shrinkage of the tumor, and the patient was then received then 2 blocks of chemotherapy. So now a few general things. You know that the most frequent sites of involvement of Burkitt's are, of course, the abdomen, and the second position there is the head and neck region, where all these different structures, the lymph nodes, the pharynx, also the bone, especially with endemic Burkitt lymphoma, and of course, structures of the central nervous system can be involved. So I think you should always bear in mind, if you have a patient with a unilateral tumor of the tonsil, that this could be a Burkitt lymphoma or perhaps also some other types of lymphomas. It could be this pediatric type follicular lymphoma, and what we have also learned recently by a study that we performed, it could also be a large B-cell lymphoma, RF4 positive, which is a specific subtype of large B-cell lymphomas. Now the next patient. This patient came from a peripheral hospital, and the symptoms that were reported to us by the parents was that the patient was vomiting, had abdominal pain and obstipation, and the peripheral hospital had no sonography available. That's why they performed this X-ray, where you can see the air fluid levels. You can see the, I think it's written there what you can see. I will not go through it in detail. So what would you do in this patient if it comes now to your university hospital?
Just a comment on the other case.
Yes?
But if you are able to take out everything, it will receive less chemo because it's stage 1 completely resected. Just a comment on that, because this
At
one.
that time we decided not to do this, but this could be an alternative to go for a complete resection, which means only 2 blocks of chemotherapy.
Yeah.
You're right. We could have also decided this way. Okay, what would you do now in this patient? Abdominal
And
pain.
don't answer, call the surgeon.
Ultrasound.
Yes.
Yes, no, of course. Of course. Blood test.
Yeah. Of course, we did a lot of we did a complete
Do not call the surgeon.
Clinical examination of the patient, and after taking the blood for all the analysis needed, we performed what you are suggesting, a sonography, and saw an intussusception, not so surprising perhaps, and a very small amount of ascites. What is the most likely diagnosis in these situations? Let's say this patient also had an elevated LDH level, which was then reported to you, and also an increased uric acid level.
How old is age?
The patient was 9 years old. Is most probably, we learned it in our liquid tumor track, the most probable diagnosis is, again, a Burkitt, I would say. Okay, we agree. Of course, it could also be a diffuse large B-cell lymphoma. It's not that it's always a Burkitt if you have a ileocecal tumor with an intussusception. Okay. This is just, I think, something you all know. What is now the next step in this patient after physical examination, blood tests, and sonography?
Try to get cells everywhere you can.
Yes, you want to get tumor sample to establish the diagnosis, but what is very important? This is now very important. How to continue now?
Does he have a pleural effusion?
No. Good, good, very good.
Chest X-ray
We did.
okay,
It was normal.
great.
Yeah.
To get the ascites and then
But the patient is not doing well. She has pain, and she has an intussusception. Yes, I think it's now the time for an interdisciplinary approach. Sitting together, already of course involving the surgeon to discuss how to proceed in this patient. The problem in this patient was that the amount of ascites was very low, because the patient had no pleural effusion. Of course, you could establish the diagnosis by ascites and pleural effusion alone. We all agree on that. We could do all the things that we also did with the first patient. You could do morphology, immunophenotyping, and fish analysis. But in this patient, we thought it might need more. We were afraid to not be diagnostic and get enough material for everything by the ascites, and that's why we decided to go for an operation. And who goes into the operation room if you have such a patient, to be there, to look at the operation, to get material for her or himself? Only a few. I think I was trained to always, if it's possible, of course, due to the workload you have on your ward, to go into the operation room to get some material. Why? Because if they perform the operation and resolve the interception and the material only goes to the pathologist, you again don't have the diagnosis because it's now with the pathologist. You should get material with yourself and do what we have done with the first patient. Do tumor touch imprints, then you have the diagnosis with the morphology, perform a fish analysis as we did it for the first patient. You can do it on both materials and perform or make tumor cell suspensions to establish the mature B-cell immunophenotype. And then, if you have the diagnosis made yourself, you can start the treatment. And you don't have to wait, let's say, 3 days until the pathologist tells you that it is a Burkitt lymphoma. Does it make sense for all of you? Sorry. Or do we agree? Okay, does not agree?
I was wondering if you should do a bone marrow biopsy during the operation.
We would do.
Okay.
We would
Okay.
do.
Okay.
We would
do that too. Yeah, exactly. And do you also do a lumbar puncture?
I think in this patient we didn't do, but I don't know whether, without having established the diagnosis, we would do that. I think this is something we could discuss. This is not black and white, because clinically and from the lab values, this will be a Burkitt or a diffuse large B-cell lymphoma. But in this patient, if I remember, we didn't do it.
Okay.
Who would do this? Who would give the lumbar puncture with intrathecals without having seen a pathological cell? So you would all postpone. And this is also how we decide.
But I have a question about it. If you have diagnosis the way you did, and then you decide on start the treatment immediately, then you will still see something in the CSF, or you?
No, we did then when the patient came back, and we saw again it needs 40 minutes to have the diagnosis by the tumor touch print, so we immediately performed on the next day the lumbar puncture and then started with the corticosteroid.
Okay. So you will do it before the treatment?
Yes, yeah.
Okay,
Yeah.
that's what.
Okay, good. Fiona?
I think another thing for an interdisciplinary approach is the discussion point on whether to wait for wound healing or no, because we should not, but we had a case with the pediatric surgeons 8 or 9 years ago where it was a massive abdominal surgery for interception, and they knew that rituximab or prednisone and cyclophosphamide was going to be the treatment. So they waited 1 or 2 weeks before referral, and then the patient was CNS positive. So I think it's also important to spread awareness.
This was very much criticized by me. We had then afterwards a meeting with them and discussed this with even with the chief of the department, that this was not justified to wait 2 weeks in such a patient with Burkitt lymphoma. Okay.
I was wondering if you. Sure, I forgot what to ask. I'll come back later. I had a question, but I forgot it.
Okay. Okay, I think we talked about what is now written on the slide, and this is how the tumor looked like. We made a photo of the tumor. Yes, and we already talked about this, the most common site of involvement of mature BNHLs, which is the abdomen with these different symptoms that might occur. And I think it was also very important that you mentioned pleural effusion. These patients with a massive abdominal involvement sometimes also have massive pleural effusions, so you can establish the diagnosis by pleural effusion alone. And as you know, that Burkitt's not only involve the gastrointestinal tract and lymph nodes, but also might involve massively the kidneys, the ovaries, and also produce ascites. So I think this we have discussed. This slide I have shown in the liquid tumor tract to all of you. I will not go through it. You know that we have a very good prognosis for primary disease. no role for radiotherapy. Surgery is only needed for diagnostics and second look operation. Risk stratification we discussed, and we also discussed extensively that we should solve the problem of Burkitt's with primary frontline therapy and try to avoid relapses. This I think we can skip. Now you remember, sorry.
We had several times a problem with the surgeon.
With what?
With the surgeons.
Okay.
Because they don't allow us to start with treatment when they have done the operation and they have the healing period. How do you deal with that? Because especially they say prednisone will stop stop the healing of the process, and you better wait for a week.
I can just comment from our experience. We had the chief of the surgical department for decades was really a really good one that we had in Vienna, and he could understand that Burkitt's need an immediate start of the treatment, so we never waited and started with the pre-phase as soon as the patient was sent back to us, and we had no healing problems. But this is only my center experience. But now, as Fiona mentioned, you're right, the current chief is a little bit different, to say it politely. And we had this problem with a nearly 2 weeks delay, which was unacceptable. I think I'm not aware of any literature and any proof that you have to wait after this operation because of healing healing problems. Everyone will have one case, perhaps, yeah, but we never had such problems. Martin.
Maybe one question: was the surgical specimen part of the intestine with infiltration? Yeah. Why did they not take out just the lymph node and left the intestine?
It was done because of the interception.
But that's not a reason for a surgery.
Yeah.
This is important to mention.
Nowadays,
it's not a reason for surgery.
Nowadays, people try to solve the interception problem conservatively. At that time, they performed a segmental resection of parts of the ileum.
I think that the problem with surgeons is that when we give the chemo, we have very quickly the drop in CBC, and since the low neutrophil count, which helps scarring, but that's not the reason to delay. Yeah.
Okay, now the classic situation. Friday afternoon, patient comes in with a mediastinal tumor. It was a male adolescent, if I remember correctly, and presented with this massive mass. So, what do we do? What is the first step? Yes, now, after the third patient, we agree, yeah? What would you do now in this patient? What is the first? We did the clinical examination, what lab? What do we do? What do we look for?
Blood smear.
Smear. I think we would go for a
so
peripheral blood smear, what we did, to see if there are leukemic cells, I expect. I think that you mean that. This was negative.
If it was Thursday, it will be possible.
What is the next step? What you could do if you have it available at your center?
Is there some effusion?
No. You are already thinking about an invasive procedure, let's say, but the question is, should we do something else before? Flow cytometry of peripheral blood, which in this patient was negative, but we would have done this.
Look for other adenopathies that should be accessible?
Yes, there was an enlarged lymph nodes in the supraclavicular region, right side. But what could we do before, and how do we do it?
I can't answer that. I just wanted to comment. You can.
Yeah. What would you do? Because no blasts in the peripheral blood doesn't mean anything. Yeah. Yes, bone marrow, but how do we do this? Would we put this patient under general anesthesia?
No.
So, okay. We all agree this is dangerous.
mildly sitting position with a good anesthesiologist,
Yeah.
just
This,
as little anesthesia as you can, and
or it's the patient was 14 years old. What could you do instead of mild sedation to be on the secure side?
local
Yes.
anesthetic only.
Yes. This is what we did, but this was also negative. We analyzed it, of course, by morphology and FACS. No T lymphoblastic cells detected. But
why did you not remove the lymph node under local anesthesia? And do then FACS and also morphology?
yes, this could be an option. It comes. You could think about a fine needle aspiration, which can also be done in a local anesthesia, then you can make a tumor cell suspension. You can have morphology, and the tumor cell suspension delivers you the immunophenotype. But we at that we did it.
I have an idea.
Sorry.
Wait, don't show. Maybe you took serum markers like alpha fetoprotein and beta ACG. There's a differential diagnosis
Very
except
good.
for T lymphoblastic
Very
lymphoma.
good. It's very good. Yeah. We usually also do that if and we did it, and this was negative. Very good point. Yeah. Yeah. Very good.
You could do TARC also. Do not.
This is done at PMC.
Yeah, but you should do it also.
But you can comment perhaps on it a little bit later. But let's say you decide on whatever reason that you will not go for a lymph node aspiration because the patient will refuse to do this under local anesthesia. What would you then do in such a patient? Yes, yes. You would start with corticosteroids to get a shrinkage of the tumor, and then operate in a more secure situation the patient, remove the lymph node, and get the diagnosis. But how long do you treat? Do you treat for 1 week? Or do you monitor this patient every day and then decide not to miss the right situation? Because we have patients with lymphoblastic lymphomas, T-cell lymphoblastic lymphomas, even after only 3 days, there is a massive reduction of the tumor. And if you do the biopsy too late, it might be not diagnostic. And then you still don't have a diagnosis. And so it's very important that you monitor these patients daily and that you have, again, a very close and good collaboration with your surgeon to decide the right time point of performing the surgery. Yeah.
Where do you monitor and receive these patients? We would do this in the intensive care unit at our center.
And this patient, if I remember correctly, was at the normal ward, but I think this is also a valuable way to go for. Yeah, I think this depends on what is the policy in your institution, but putting such a patient for close monitoring on intensive care unit is more than okay, I think. It depends how you.
Only if you take care of the patient, not because if somebody takes care, he will give potassium or cortico. Something, but yeah.
So what do you do? I'm sorry that I already showed it. What do you do if this patient does not respond? And usually what is important, you start with full dose of corticosteroids, because if you start with very, very low doses, it will not help. So we usually start with 60 milligram per square meter per day. It's also written in the protocol. But what do you do if this patient does not respond, let's say after 3 days? What could be an option? For me, it's very important, this discussion here is not that there's only one way to go, and I'm not telling you how to act with your next patient. There are different ways to go in such patients and to get the diagnosis.
You can give 1 dose of cyclophosphamide?
Yes, this could be an option to add cyclophosphamide, either in a fractionate way or one high dose. This is both possible. Or what could you do? Let's say we give and the patient still does not respond. We have T-cell lymphoblastic lymphomas that don't respond. It's rare, but they are existing to corticosteroid and cyclophosphamide. We still don't have the diagnosis. Yeah? What could you do?
We could talk to our anesthesiologists and intubate him in a very controlled fiber optic way.
Yeah. And this is not a mistake. Yeah? If you don't have any way to find a diagnosis, it is justified to intubate the patient, ventilate him or her, perform the operation, then start the correct treatment or intensify the treatment, and then extubate the patient when he has responded and there was a shrinkage of the mediastinal tumor. This is what I wanted to also share with you. So here you can see the response after only 1 week of corticosteroids. So you see how rapid lymphoblastic lymphomas can respond. It's very important. That is why it is important to make the diagnosis as early as possible. Here you see the X-ray after 5 weeks of induction therapy. So, next patient. This was an infant who presented with this tumor to us. What is different from the other case? Where is what? Pardon? I don't know. Yes, it's a posterior mass. Yeah, so this is a very important message, of course, that this is a tumor in the posterior mediastinum. So, what are the how would you proceed with this patient? It's an infant patient, as you said correctly, with
neuroblastoma.
Yes, it will be a neurogenic tumor most likely. Yeah, you're right. What we also saw was the infiltration of the neuroforamina. So this is nothing which is done usually by mediastinal non-Hodgkin lymphomas. Then we would of course look for parameters associated with neuroblastoma, so for the urine catecholamines, LDH and ferritin. And in this patient was really compromised. She was in a very bad clinical situation, and we put this patient immediately on the intensive care unit. As soon as we saw the imaging, we decided to treat this patient without a biopsy according to what is foreseen for neuroblastoma, and planned already the operation with the surgeons before the aplasia comes from the first chemo block, which was carboplatin VB16 according to the Linus protocol. And the diagnosis can be done later. You don't have to wait for all these important molecular genetic diagnostics of neuroblastoma when you have such an infant in such a bad situation. So the diagnosis, as you said, was infant neuroblastoma. It was with only numerical aberrations, and you can see how well this patient also responded to the chemotherapy, to the first 2 courses. We then went for a watch and wait, and the patient never relapsed. Okay, I think in summary what is important about mediastinal tumors is that very often it's an incidental finding. It's not that they always come with symptoms, but the symptoms, of course, are caused by the compression of the nearby structures. And here you can see, of course, the typical symptoms of a mediastinal tumor, of a tumor in the anterior mediastinum. I will not go through all of them because I expect that you know all of them. And here you can see the structures that are compromised usually by the mediastinal tumor and cause the respective symptoms. Whereas the tumors in the posterior mediastinum usually cause neurological symptoms plus respiratory symptoms, which was the case in our patient due to the compression of the nerve roots and the spinal cord. I think this is something you should know as a pediatric oncologist. What are the differential diagnoses of tumors which arise in the mediastinum, so that you can make a good diagnosis. And that's why it was very important that you mentioned the germ cell tumor markers AFB and beta HCC. Okay, now this patient. This infant was brought to us by the parents with this lesion here. The infant was doing very, very well, no clinical problems. You did not find any other pathology during your complete clinical examination. What?
Blast, yeah.
No, it was not the blister. Sorry, I did not get it. But what was the next step? What do we examine again? Pardon? The spine. No, I would not start with this. Who checks the blood? We. only very few. I think we should check the blood because this could be a lymphoblastic leukemia, which has an infiltration of the skin. This is very well known. So, of what?
Well, you have a mass on the back. I would start with an ultrasound.
Yes, you can do this, and you see that there is a pathological mass confined to the skin.
I would make an MRI. And then take the blood.
No, but what? Honestly, why doing an MRI if the sonography shows you have a small mass infiltrating the skin and not going into more deep structures? You will not get.
I'm joking, Andisha,
okay.
but I would ask the radiologist if they can make a differential diagnosis, and then usually they say, no, I cannot, please make an MRI.
Yes. Okay, but we started with a peripheral blood smear.
Can I say, Andisha, because you're very hem-onc minded, this could be a dermatofibrosarcoma protuberans.
Yes. I agree. But we have not yet established the diagnosis, because this disease has to be established by histopathology, I would say. We agree. But we can find other ways perhaps to make a diagnosis, but at the end perhaps we have to do the biopsy. But I think in this patient we decided for a peripheral blood smear which was negative. What would you do in addition with the peripheral blood again? I would do a flow as the next step, which was again negative.
You didn't mention, was it Friday or Saturday?
Who would go for
a question for the flow?
Yeah.
If you don't see in the microscopy, so in the cytomorphology, no blast, so the recovery is great, and then you have a flow with like, I don't know, a population of 2% or 1%, what would you do different? Or
now, what we have definitely learned by Michael Dvorak, he's the European expert, that he can definitely identify the leukemic blasts by flow cytometry in all patients who have a B acute lymphoblastic leukemia. So if we find by flow cytometry a distinct leukemic population, we know it is ALL, and then we already put the intrathecal in by the lumbar puncture when we perform the diagnostic bone marrow puncture. This is something which has been proven very efficiently, and this is for sure.
Because we wait for...
Interesting. No, but let's continue. Or Bob, you want to say something? Then let's.
Yeah, just some of us aren't obsessed with everything being hematologically wrong, and there are other things in the world, people, and you can't always diagnose them by flow. And sometimes it's just much easier to get somebody who knows what they're doing to look down the microscope rather than having a guess.
Yeah. Okay.
Except if you're Andres, obviously, where he really knows what he's doing and everything is a hematological malignancy.
Okay, we performed the bone marrow puncture. But let's continue. Let's continue now.
Andisha,
No, wait.
Can I just ask, sorry if you mentioned this previously, but how was the child systemically? Because we saw the lesion. Fevers? No. Okay.
But
if you know about the disease the patient has,
yes,
you know it's a very critical situation. I'm not joking anymore.
But
this is really something you should keep in mind.
But why would you do a bone marrow puncture that is more invasive than a skin? You could just do.
We would usually
have a superficial skin lesion.
We would do.
Why
We
don't you
did
just biopsy
both
that?
together, of course. So we did in one procedure. We performed the bone marrow puncture and also performed a skin biopsy. The bone marrow puncture was negative, but the skin biopsy showed you the lymphoblastic cells. We did again a tumor touch imprint, and there were lymphoblastic cells. The FISH analysis showed the KMT2A rearrangement, and the tumor cell suspension proved that it was a pro-B immunophenotype. And B-cell lymphoblastic lymphomas typically can present like this. The most common sites, and I will show it to you later, so we completed the staging, started the pre-phase. A lymphoblastic lymphoma, you know 75% of a T-cell phenotype, 25 B-cell phenotype, and the B-cell lymphoblastic lymphomas typically involve the bone, skin, bone marrow on a very low level. Per definition, it has to be below 25%, and the lymph nodes. So this is a typical situation. It's not so unusual when we talk about precursor B-cell lymphoblastic lymphoma. And the cells, of course, look the same way morphologically as the patients with acute lymphoblastic leukemia. So now, again, some general comments, but I think you all are aware of the symptoms that T-cell lymphoblastic lymphomas cause. We discussed that this is an oncological emergency situation, that we have to solve the problem, the diagnostic problem with a minimal invasive diagnostics. These are the take-home messages for LBL. Again, very good prognosis, 80 to 85% event-free survival. We have omitted in almost all protocols the prophylactic cranial radiotherapy, although this led to a slight increase of CNS involving relapses. Surgery only needed for the diagnostics. Risk stratification currently done in our LBL 2018 protocol is by stage of disease and genetics. And again, the same situation for TLBLs as for Burkitt's. If they relapse, they have a very poor outcome, and you can only cure them by allotransplant, but you have to bring them to allotransplant, which is the most challenging thing. Okay, I will not go into the details of the LBL protocol. Then I think this is almost the last patient. This patient did not come to our hospital, but came to a peripheral hospital and was referred to a neurosurgical department. There was this soft tissue tumor, no B symptoms, and no peripheral lymph nodes enlarged. The patient was quite okay. What would you have done in such a patient? Ultrasound, we saw a pathological mass there, not infiltrating the meninges and not infiltrating the brain. What would you do?
Biopsy.
You go for biopsy. Bob?
I'd ask someone else to biopsy it, because it looks like they've got it really ready already, so I wouldn't be doing it myself.
Yes, I think in this case we would also do the MRI. I think, Reineke, you agree? But we were never involved in this patient. And this was a mess, because the neurosurgeon decided to go for an operation, and it was not that he went for biopsy, which would be the correct way to go. He thought, I can remove this mass completely. And he started operating. And by this, he harmed the meninges, and the patient developed a liquor fistula. And when the diagnosis came, the patient was referred to us in this situation. We were never involved. It was really a bad situation. And we would have done, if we would have been involved from the beginning, of course, a biopsy. Again, we would perform a tumor touch imprint, but the diagnosis of this disease entity by cytomorphology is usually not possible. It's not so clear as it is for Burkitt's or lymphoblastic lymphomas. We would go for a tumor cell suspension, by which we could also not establish the diagnosis, but we performed an ARC-FISH because we were already thinking about the diagnosis, that it could be an anaplastic large cell lymphoma, and most of these patients are, of course, ALK positive, and the FISH proved to be positive, so we had the diagnosis. And the right way to go would have been to do the biopsy, to get the histopathology, but also our analysis. So no debulking surgery is, of course, needed in such a patient, we all agree. And as you all know, but I will not go into the details, anaplastic large cell lymphomas can present very differently and have a very high tendency for extranodal involvement, as you can see here. And the skin involvement can be very, very diverse. It could look like a bite from an insect, you should be always aware of this very different picture these patients might have. But this was a catastrophe because we were not involved at any time point till the diagnosis was established in this peripheral hospital, and then the patient was referred to us. So these are the take-home messages for ALCL. I think we have to now finish, but you know that the prognosis is not that good as it is for perhaps lymphoblastic and Burkitt's, but they have a very good second chance. So this is important. And at the moment, we have developed different ways how to approach this disease. And I can show you what is currently recommended in Europe, how to deal with an ALCL. We are not stratifying these patients by stage of disease, but by minimal disseminated disease as measured by the NPM ALK load. Those who are negative now enter the ALCL vinblastine monotherapy. So 2 years of vinblastine monotherapy, whereas those who are MDD positive are treated by chemo according to our very old ALCL 99 protocol. And those who become MRD negative continue with this old chemotherapy protocol, whereas those who are still positive have a very, very poor outcome. And here, at the moment, we would recommend to include these patients in the BRIGA-PET trial, even to refer patients to these centers who are open for this trial. So by this, I would like to finish, and you see how controversial it is to discuss such patients. It's not always easy. It depends on many different factors, how to deal with such a patient, and I hope it was somehow interesting for you. Reinecke.
Well, thank you for mentioning the BRIGA-PET study, but I think it's good also to mention the second study.
Yeah.
You can consider the CRISP study, and I think you need to realize if it's a very rare disease, you should try and treat your patients on study. And the CRISP trial is for crizotinib. There's 2 strata for ALCL patients, one for the lower dose treatment of crizotinib or in stratum 3 for the registered dose. So also refer them for that study.
Can I ask you the age of the inclusion criteria in that studies?
It's, I think we should request an AYA stamp from you because the BRIGA-PET study goes up to 26, I think, saying by heart. For the CRISP, it's not an AYA stamp valid study. We tried to increase the age range, but didn't make it yet. But we'll do so for the next one.
Well done.